From Faith Forward Media, this is Healthcare Musings. I'm Dr. Hesham Hasabala. Welcome, everybody, to Healthcare Musings. It's Hesham Hasabala here. Very nice to have you. And I am delighted and honored to welcome to the show Dr. Elaine Chen. She is Associate Professor of Medicine at Rush University Medical Center. My alma mater as well. I did medical school residency fellowship there, and so did she. So she's a graduate of Rush Medical College, so we're schoolmates. She did her residency at Rush. She did her fellowship at Rush in pulmonary critical care, and then went on to Northwestern University and completed a hospice and palliative care medicine fellowship. So why I wanted Dr. Chen on the podcast, I've had other episodes where we talked about palliative care and this recent research that most oncologists don't refer to palliative care. And there was a survey that had zero oncologists refer to palliative care, which shocked me, right? And I wanted Dr. Chen to come on the show because her perspective as an intensivist and a palliative care physician is just very unique and very unusual, and I think is really important for clinicians and intensivists and just the medical community in general to hear her insights. So welcome, Dr. Chen. So happy to have you.
Thank you so much for that lovely introduction and that intriguing starting concept.
Absolutely. I think I'll say it either bet. I think intensivists, I think by default, we are providing palliative medicine in the ICU all the time because just like this research says, despite the American Society of Clinical Oncology recommending strongly to refer to palliative care early, and nobody does it according to one survey, we're forced to do it in the ICU, and I'm happy to. I love doing it. I really do. I think it's part of my mission as a critical care doctor. And it's too late at the same time. It's too late when I'm doing a palliative care discussion in the ICU. So I just and your perspective is very unique. So what do you think about that?
Well, I think I agree with you 100% about intensivists. Every intensivist needs to have a good, strong palliative care skill set because we know that more Americans die in the ICU now than before. People are expecting to be able to live longer and for medicine to be able to reverse things. And so by the time we get to the ICU, people are like, oh, well, can't you continue? And so there's a lot of death surrounding any physician, any nurse, any clinician that takes care of people in the ICU. I wanted to get a little bit to the oncologist, and I definitely have to take a look at this survey about 0% of oncologists referring to palliative care. And I'm sure there are nuances to it. In our hospital system, the oncologists, and it has taken some time, but over the past decade, have really embraced the palliative care co-management alongside their sick palliative care, their sick oncology patients who may be at the end of life and it may be time to transition to hospice and start treatment, or it may be much, much earlier, whether it's multiple comorbidities, frailty, or simply a lot of symptoms and side effects of chemotherapy that need co-management and another member of the team walking alongside them. So I do hope and believe that palliative care is starting to become much more common upstream in the cancer patients. However, I know that the availability of palliative care staff is limited. And let's be honest, the availability of time for other clinicians is super limited as well. In the ICU, you have a handful, a lot. It varies how many different people you are caring for at the same moment. And while nobody discounts the importance of sitting down with a family and talking about all the issues that are putting the patient at high risk for complications, at high risk for death, if there are competing issues going on and the patient next door has the potential to be saved, you're going to be saving that patient that has potential to be saved. So unfortunately, sometimes these important conversations get delayed and deferred.
Yeah, absolutely. I mean, I think I wish we could get, not all of us can do a fellowship in palliative medicine, right? I wish we would be able to get some sort of credential, not necessarily just training, which training is important. I mean, you came to our hospital. We work in the same system. So you came to our hospital and gave a wonderful talk about palliative care in the ICU, and it was fantastic. And you continue to be a resource for me. And I'm lucky that I have you as a resource. And I wish intensivists can get some sort of credential because we're doing it all the time. And most of us are not going to go back and get a fellowship. And I keep looking for that. And maybe do you have, is there a way that I as an intensivist, and I would love to be able to get some sort of credential or training or certification in palliative medicine?
Well, it depends on what you're talking about regarding a certification or credential. And part of me feels that as a physician, communication is so much at the heart and soul of what physicians do that with ongoing training, I don't know what the need is for like a bunch of letters after your name to say, I'm an expert in talking about end of life care. I mean, for me as an educator, that matters. But for you as the clinician at the bedside, who is it that needs that? Your family, your patient just needs you to sit down and listen and be compassionate and have those skills. Um, Board certification is one thing. Obviously, that's intense and takes a lot of time. Before I started training, back when you were in training, actually, there was this non-traditional route to palliative care certification where you could get certified by logging a certain number of hours and taking the boards. By the time I was finishing up my training, the option for that had sort of petered out, and fellowship training was really recommended. And this is a while ago. This is 2011 was when I did my fellowship.
Oh, wow. Okay. Yeah.
Um, but there are, I'm involved peripherally in a program called the Coleman Foundation training. I don't even know what it's called, but the Coleman Foundation offers this ongoing training session for multi-professional, interprofessional clinicians who want more education in palliative care. I don't know what kind of formal certification or anything is offered, but it's definitely something that you could write down on your CV as saying, hey, listen, I am getting certified in palliative care.
Oh, I would love that. And we'll post that in the show notes, and I'll follow up with you afterwards so we can start and get more information about that. I think it's important. Where, how has being a palliative care physician, helped you as an intensivist?
Well, I think it changes the perspective a little bit. We all know that death is inevitable. It's not a failure. And I mean, I think it is a huge privilege to be able to be with patients in that setting and to walk alongside them and their families as they are approaching a transition. Um, and I think that my training and I guess my lens on it makes it so that I am honored, and I guess I feel very have a lot of personal satisfaction when I'm able to walk someone through that process and help it be, shall we say, less awful. I mean, it's not, walking through the loss of a loved one is never easy. It's really hard, but to be able to have it be more graceful, less traumatic is something, it's a gift that we can really give to people, and that I it gives me a lot of, like I said, personal satisfaction to do that.
Yeah, I feel the exact same way, and that's a really great way to frame it, is that you're helping someone make that transition of something that is inevitable for everyone, despite the fact that there are people now that I've listening to on social media, they're saying that this might be the generation where we don't die. And I just chuckled and I just said, I don't think that that's going to happen. Don't think that that's ever going to happen where we're just not going to die. It's and so how we I often say, and I want to get your thoughts on that. I often say that we don't pick where or how we die, but we do have a choice, or we are owed, or we have the right to um, have the terms of our death determined, right? So if we have the terms of our death determined, then that is most important. And I wanted to see your thoughts about that.
When you say the terms of death, I see.
How I die. Do I die being with my head, my chest pounded on? Do I die being shocked to death, or do I die with comfort with my family? with everyone sitting around me. You know what I mean? So how I die is is just as important as what when I die, or I can't control when I die, where I die, from what I die. I should be able to control how I die.
Well, there are caveats to that, of course, but when people, it really gives us a lot of peace and it gives patients a lot of peace to be able to die on their own terms, as you say. What does that mean? Like having a little bit of control over a really uncontrollable situation. So I said there's caveats, you get run over by a truck, you had no ability to control that. You die on the
Right.
spot, right? But for people with serious illness or critical illness that wasn't serious before but became serious during the hospital stay, sometimes there is some control that the patient and the family can have over that. And having control is really what I think you mean by,
Yeah.
having it happen on their own terms.
Right.
So the ability to give patients and families as much control over that process as possible is kind of what we're trying to do here. So when I talk to people in the outpatient setting about it, if you had a choice about where you would die and what it would look like, what, think about it. Nobody wants to think about it. I ask them this and everyone's always like, no one's ever talked to me about that. I haven't thought about it. I haven't talked to my family members about it because nobody wants to talk about that.
Yeah.
But then some people do. And they say, and these are the people you never see, Dr. Hasbala. They never get to the ICU. I want to die surrounded by my family. I don't want to be hospitalized. I don't want to be on life support. I know that I have a serious illness and it's going to happen sooner than later. So do all these things to prevent me from getting there. So we do that sometimes. Those are the hospice referrals at home or not hospice. Hospice isn't necessary for everyone. It's just an additional layer of support at home, but being able to die, everyone says, I just want to die in my sleep. It's what everybody wishes, right?
Me
I just
too.
want to die in
I
my
do.
sleep.
Yep.
Nobody has to be like worried about it. It happened somewhat suddenly, but not terribly. People were sort of expecting it, but like you can't always get that. So I was talking about the outpatient setting and then I was flipping over to the ICU. Once you've got to the ICU, you have a little less control over that. But there are things we can discuss and talk about so that even within the ICU, which is a situation where patients and families have so little control, they feel so overwhelmed by everything that's going on. There are things that we can give them to have more control over the situation as much as possible. So,
So what are those things? Yeah.
you know, if they are not yet on mechanical ventilation or advanced life support, do you want to try it? You want to have a time limited trial or not? Do you want CPR or not? At some point that it's out of their hands if people are really, really close to death. And for some people, the what they want is to have everything, no matter what its chances of preserving life or quality of life. They want it all in order to stay alive for as long as possible. And part of what we do is to try to honor people's wishes within reason. So what does within reason mean? And different physicians will take different approaches to that regarding how much what they will offer, what they will not offer, and how they communicate that to patients and families.
Yeah, absolutely. One thing I really appreciated when you had spoken to us is about when we say withdrawing care, and it's a little bit different. What we're doing is we're withholding or withdrawing aggressive artificial life support, right? And allowing them to and caring for them, and with a focus on comfort, because a lot of times people we're it's like we're giving up or we're pulling the plug, which I hate that, but that's not what we're doing. I love how you framed that.
We're providing care for people up to and even beyond the time of death as much as we can. That's our Hippocratic oath as physicians, right?
Hmm.
But for some people, that means the physician telling them, even before we get to the life support or before CPR, we have done everything possible to try to reverse your situation. And now we need to shift our focus. And some people will take that. They'll be like, thank you for trying everything. I am at peace now. We're going to shift gears now. Other people will say, I don't care. I still want you to do that. I still want you to do chest compressions even though I'm already on all the life support, even though the chest compressions won't work. And I'm a little conflicted about that. Personally, I believe it's my job as a physician to say, hey, you're already on mechanical ventilation, you're already on vasopressors, to try to reverse all of that. The whole point of CPR is to get the mechanical ventilation and vasopressors time to work. If you're already on all of that, what is the physiologic benefit of doing chest compressions other than causing pain and rib fractures, potentially bleeding? And so it's always within reason, because you have to, at the end of the day, the patient and the family are the ones who are being treated. They need to wake up the next day feeling confident that they did in their conscience what was needed. But also, we as clinicians need to be able to go to sleep at night and come back to work the next day to be able to continue to treat patients and their families. So do you want me to go on, or do you have
Yeah, yeah, no, no, no. Because I was thinking like there was a lot of distress during the pandemic because we were providing futile care a lot. Like there were people who were rotting, literally rotting in the in the ICU, and the family. It was difficult for them to be able to let go, and it really caused a lot of distress on the clinicians, on the docs and the nurses, right? So I think I love how you mentioned that. I think we're not only treating the the patients and their families, but it's also clinician well-being is important too.
100%. And I have sessions that I work together with a chaplain to teach on clinician well-being and compassion fatigue and burnout, and how prevalent that is within the healthcare community, and what tools we can kind of use to dig ourselves out of that tough place as clinicians. COVID was really interesting, because I think for me personally, at the beginning of the pandemic, I felt a lot of that. What are we doing here? These people are, like you said, rotting. They're never going to recover. But COVID actually changed my perspective a lot, because there were so many people that had no business surviving that recovered and survived and are walking around right now. So that's what was really poignant about the pandemic, because it was such an acute illness. Um, they were well, they were sick, they were dying for weeks and months, and they recovered. And then there were so many people that had no business dying at all. Young people, healthy people, no other conditions, who got COVID and nothing else. So maybe, a couple things, those comorbidities, who, despite everything that we did, died, whether slowly or quickly. It was really,
Yeah.
really hard on everyone. And I feel like, now it's 5 years past, and it is that time of year when things were starting to ramp up in 2020. I feel like everyone's been talking about it a lot, reminiscing about what it was like during those early days as we were learning.
Oh, absolutely. No, I mean, I was saying we were practicing in the beginning with fear, ton of fear, for the unknown. We don't know this virus. We see it. It's killing people before our eyes. We're afraid to get it. We're afraid to give it to our families. We don't have any treatments really, maybe steroids, but that's kind of it. Then the vaccines came out, and then after that, it turned into anger because now the pandemic didn't let up. It actually, if anything, it got worse as the different virus, the virus mutated and into different strains, and it got worse. And then everyone that was coming in was unvaccinated, and we're done. Like we're done with the pandemic, and people keep coming. It's not stopping, right? So then it's anger, and then it's just exhaustion after that. So it's very difficult to practice in each of those environments mentally from our perspective, right? So it's just interesting to look back upon that, and I think if I said it in my previous episode, if I had my way, every patient would be screened for palliative care, whether they're 18 or 98, right? Is that something that you do? Is that something that you recommend as an intensivist and palliative care physician?
It's hard to know what you mean exactly by everybody being screened for palliative care. I think if anybody who walks into the ICU is going to be suffering. So what does palliative care mean? It's relief from suffering. So from that perspective, everybody needs some sort of palliative care.
Like, do you have like a tool that you have everyone answer, even the 18-year-old DKA patient? Is there like a tool, like a screening tool that say, if this patient screens positive for these criteria on this validated screening tool, they should get a palliative care consult? That's kind of what I'm thinking. What are your thoughts about that?
Yeah,
That
there's,
instantly would make people like you busy, but I think that's the point from my
well,
perspective.
I, there isn't anything exactly like that. And I think it's, a lot of the things that would screen positive would be things that people need psychosocial support and not necessarily a palliative care consultant.
Mm,
Because so much of the suffering for people is mental illness. And there's no question that that is on the rise today compared to 50 years ago. Or maybe it's not on the rise, maybe it's just more recognized now. But so to me, for palliative care, the importance is that there is serious illness of some sort. And generally beyond the ICU is a little bit different, but in the ICU, is there life-threatening illness now?
mhm.
Outside of the ICU, is there life-threatening or chronic serious illness underlying everything that's causing, putting somebody at risk of suffering, or alternatively at risk of death? Uh,
Okay. So I was then that was my next question. So in the ICU, who should I now? We don't have the as robust as I would like it. And who in your opinion, if as I'm seeing people in the ICU, who should I have palliative care come in and consult with me from the get-go? In your in with in your expertise, in your opinion.
Yeah, so I think there's two concepts I'd like to talk about now. First is the concept of primary palliative care, which is that every clinician should be providing a basic level of primary of palliative care. That's primary. That's you as the primary care, the primary intensivist in the ICU. It's the primary care doctor in the outpatient setting. It is the um, hepatologist taking care of their patients with cirrhosis. It is the cardiologist taking care of their patients with heart failure. It is the pulmonologist taking care of patients with COPD or ILD, right? So that's primary palliative care provided by the first line clinician or
Okay.
even the bedside nurses. Bedside nurses provide a lot of primary palliative care. And the
Absolutely.
specialty palliative care is when it goes beyond the basic level of providing some psychosocial support, planning for the future, ensuring that there's an appropriate surrogate decision maker or power of attorney, and basic symptom management, right? So for specialty palliative care, who needs that? It's when you can't handle it, or when there are things that you haven't recognized, or when, families want extra support. So how do we decide who gets the specialty care or who's going to be the primary palliative care clinician? And part of that is, I'm just coming off of the palliative care service, and we got more and more and more goals of care consults. How much should the primary team be doing? How much should the palliative care team be doing? Those are
Mhm.
really hard discussions. The palliative care team is definitely more trained to do it. And theoretically, and this is where, the volume matters, palliative care takes a lot of time. Who
It
has the
does.
time to do it? It really depends on the day and the staffing models and the number of clinicians available. Okay, so in terms of like having a guideline to make referrals, is that, are there triggers? Are there, you talked about screening models, are there AI models? All of those exist and have been studied or are being studied. So, there's a bunch of papers from, I don't know, the first one probably came out in 2010 about proactive palliative care in the ICU, where if you meet certain criteria, then you should get an automatic palliative care consult, whether it is a nurse, an advanced practice provider, or a physician, a social worker, the full team, whatever it is. And there was one model with a number of criteria. And then I think in 2020, probably 2019, 2020, before the pandemic, another paper came out. And this one was out of WashU about the same thing, a different set of similar triggers. And if you met these criteria, you got an automatic palliative care consult. And was there some benefit or not? And in my institution, actually, we had a researcher who took that model and sort of applied it to our ICU and did sort of a relative randomized one unit versus the other unit to see what the benefits were. Um, and then even more recently, I think it was in 2024, another paper came out about automatic consults. And the literature has been, I don't know, it's not a slam dunk. For
Really,
the most
really,
part,
that's so surprising. That really,
yeah, for the most part, the earlier studies said there is benefit to this in terms of patient and family satisfaction, other things, other metrics that we're looking at, changing of code status to DNR, decreasing length of stay in the hospital and ICU, because a shorter length of stay means less time spent suffering in uncertainty,
right?
and cost savings because there's a decreased length of stay. And I don't remember the newest paper. I just remember this was intriguing. There's not benefit here, so I need to go back and read that again. But and it may be that there are more palliative care consults being called in general now than in the past. I don't know. Um, but it was like doing those triggers, those proactive triggers were really, really time intensive for whoever the researcher was. And it
Yeah,
really became not a feasible model to apply in the real world. In our hospital for a while, it was like the nurses were calculating these points. And if they met a certain number, the nurses, this is the consult culture. Nurses are not allowed to call a consult. It has to be called by a provider. So
right.
then they were doing this roundabout system where the nurses would notify somebody, and then somebody would, the palliative care team would reach out to the provider. It was burdensome. Currently, our
Yeah.
hospital is working on a system. It's a AI-driven model, and it's a little bit controversial, and it's not, ready for prime time, but a number of objective findings that the model, the AI driven model, will search the chart for and say, well, this patient, based on these numbers, may benefit from a palliative care. Well, actually, the specific model has a high risk of death, right? So this patient
Okay.
has a high risk of death in the next 6 months. So if someone has a high risk of death, then advanced care planning is probably beneficial. Would a palliative care consult be beneficial? And so we're building this model and trying to figure out how it works in the real world. And we're in a pilot phase right now. So I don't want to talk too much more about something that's in a pilot phase.
Sure. No, that's interesting. If I guess we'll connect offline, and maybe if you have those papers, I can put them in the show notes as well. Um, do you think I am starting to write in my chart, not DNR, because DNR has such this negative connotation that we're just like, oh, they're DNR. We're not going to do anything. Where I really don't get your thoughts. I really want to maybe change, and some hospitals have DNR to AND, allow natural death, because that's really what we're doing. We are not resuscitating, and we are allowing the patient. And even I don't even like the term allowing, like I am in charge of their death. Like I try to word it so that the patient has indicated that CPR and defibrillation is not consistent with their values and preferences, and wants a natural death, and so will not be resuscitated in case of cardiac arrest. Do you think we should change DNR to AND? I want to. What do I'm curious to get your thoughts about that.
My personal opinion is that it doesn't matter.
Really? How come?
Yeah. So I think it's the concept and how it is discussed that matters and not what the order is. And that when you explain it properly, then patients are okay with it. And
Mm,
the thing is, so,
that's
palliative
a good point, I
care,
guess.
people have long associated palliative care with death, right? Especially in the olden days, I don't
Right.
know, 15 years ago. I'm not ready for palliative care. I don't want to give up. I'm not ready. I don't want you to pull the plug on me. Don't call palliative care. Palliative care equals hospice equals death in 5 minutes. And there's still a lot of stigma about hospice. I was talking to a cancer patient this weekend or last week. Oh, well, you can proceed with chemo. And when you're done with chemo, then I would recommend hospice. No, 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 I don't want hospice. Well, this is what hospice means. Hospice doesn't mean you're going to a nursing facility and they're going to dope you up until you're dead. Hospice means that we're going to walk alongside you and keep your quality of life at home the best that it can be for as long as possible. Oh, I want that then. right? So
Oh, yeah.
it's all about explaining what the language means. Then they talked about, changing the name of palliative care to supportive care team or whatever. And so they tried that. This was maybe 10 years ago, 15, I don't know. I say everything's 10 years ago, so I don't even know. But there were studies done about that. And basically what happens is people get through the language to the connotation and sort of figure out what you're talking about.
Oh, really?
And there
So,
is so much more. We get a lot of people now, we get families saying, hey, I want the palliative care team to come and support us here. I don't even know why. I just heard it was a good thing. So can you guys come for us? And then the other thing is actually, it was on my dining table this weekend. There was a paper out of Chest in January that was about changing the do not resuscitate to beneficial care only. I think it was like BCO, something like that.
okay.
And it was interesting because it was written by an old colleague of mine, Dr. Gina Piscatello, who
Hmm.
was the leader of the research project we did here in our ICU doing the proactive palliative care, the triggers. But she did it all herself. It was really time intensive, and so it wasn't sustainable after the research project was done. But she wrote this research paper in Chest about beneficial care only versus do not resuscitate. They did a survey of 600 people, and basically at the end of the day, it doesn't matter what you call it. It is how you
Interesting.
explain it and how you how you sell it. So that was
Yeah, I'll try. I'll look for that paper and put it in the show notes. Wow, that's surprising. That's surprising. I definitely try to say, we're going to let you die naturally. I'm not
I
going to pound you on your
definitely
chest.
say that. I definitely say that. So, at the time of death, this is like what you're saying, like how I want to be allowed to pass peacefully. I want my
Yeah,
family by my side. Okay, great. That means that we'll let you pass peacefully. That's the same as a do not resuscitate order. So I'll put a DNR order in the chart to ensure that that happens. That's what I say. And
yeah,
most of the time, people are like, okay, that's fine. It's not that we're not doing anything, it's we're not doing a non-beneficial treatment. There is no benefit to this. I said it last week to a guy with heart failure, an EF of 10%. Just CPR won't work on you. It won't bring your heart back because we already know that your heart is in its terminal phase. And when we said
yeah,
that, he was like, oh, okay.
yeah.
So
Because people think we're giving up on them. We just don't care, right? It's just, oh, let them, whatever. And
yeah,
yeah, that's interesting. So,
people
so
just need to
what?
believe that you have their best interest at heart and that you are doing everything in your power to make them better.
Yeah, no, that's a fantastic point. So, when explaining hospice to patients and their families, what is a great way to do it to make them so that they don't think it's just, oh, we're just dumping you in a nursing home and doping you up until you die, which sounds outrageous and hilarious, but that's interesting. That may be the perception. How would you recommend critical care clinicians to explain hospice? Because we're doing it more, and there are hospital systems that are really pushing getting people enrolled into hospice in the ICU. It's a big push in a lot of hospital systems that I see. So well, how can we frame that conversation?
Yeah, and the ICU patient is a little different than the
Right.
ambulatory cancer patient who is stopping chemotherapy. So, from the ICU perspective, I mean, they are going somewhere, right? If we're withdrawing life support, we are sending them, pardon me, to a facility, an
Mhm.
inpatient hospice, where the clinicians are specialized in comfort at the end of life.
Okay. And then
And
they get bereavement for the family, right? Is
there
that a
is a year,
standard?
13 months of bereavement. And actually, the hospice bereavement benefit is even available to people who don't elect hospice. I'm not quite sure how it works, but you can make a referral to a hospice agency and they may be able to provide bereavement services. 13 months is key because at the
13
anniversary
months.
of death, that's a really, really tough time for people.
It is. It is. It is. I say a lot of people. My wife and I, we lost our oldest daughter to cancer. That'll be 16 years ago this year, and so the first year that I call it the year of firsts. It's it's the first Christmas, first birthday, first Disney show, first everything, right? Until first birthday, first until the anniversary, right? And then you can kind of move on, right? Because you're not thinking, oh my God, this is the first time without her, first time we're doing this without her. So yeah, that's interesting that it's 13 months because you are right. That first year is super, super hard, right?
Yeah, but you were asking like how do you explain hospice to somebody
Yeah, yeah.
in the ICU? Well, I mean, it is a place when you're coming from the ICU.
Okay.
It's a place of transition to death or recovery. And if people recover, they sometimes go home from the inpatient hospice, still with hospice services. It can be revoked at any time. But in the setting of somebody who is pretty imminently dying, hospice is a place where they are focusing on the care and symptom management of someone who is dying to make sure that that process is as smooth and calm as possible. It's a more home-like setting. There are more liberal visitor hours, so you can have more people or more hours of the day, and it is calmer and quieter.
Mhm, mhm. Do you think hospice at home is better than hospice in a inpatient hospice facility, or even general a GIP bed where the hospital bed gets converted to a hospital? Does it matter? Does there research on that, or whether hospice at home is? I know some people you can't do it, like someone's vented and on multiple vasopressors, you can't do that. But what has been your experience with people going home on hospice?
There are different patient populations.
Okay.
If someone has the ability to choose home hospice, it is better than the inpatient setting. The inpatient setting is so inpatient hospice is a short term, it's meant to be a short term transitional phase when
Mhm.
there are active symptoms to be managed, when patients need 24/7 nursing monitoring and need a physician to see them every day or a provider. At home, they get to be independent, they get to be in their own space, they have the things that they are accustomed to and loved ones are around and more comfortable. Definitely
Okay.
better. But as it transitions and care of a dying person is really, really hard for the caregivers.
Yeah.
So
Yeah.
if family can't provide that 24-hour support or can't afford to pay for a caregiver because caregivers are not covered by the hospice benefit, what are they going to do? But that kind of custodial care, cleaning, bathing, dressing, feeding is not something that is an indication for the inpatient hospice unit. So what are
Right.
the options? It just becomes a really difficult question of money rather than philosophy.
Right, I see. It made me think that sometimes people are in hospital. Like when I get it, oh my God, I can't believe they come in, they call 911, and they get intubated. I think should there be counseling or preparation for when they die, like what it looks like, so that they don't panic and just call EMS?
For hospice patients
Yeah, for
or
hospice patients. Yeah.
um, absolutely. And that is a huge important part of the hospice team's job.
Yeah, because it happens a lot of times where they just panic. The patient is dying, they are dying, and then for whatever reason, EMS is called, they panic, and then they come in, and then they say, "Yeah, I do everything." Then they intubate them, and then I look at the chart. There's a post form, and to me, as a critical care clinician, that's anathema, right? So I wonder, yeah, it's just kind of, and it happens a lot more than we want for it to happen. So I think that's really a good point, is that they need to prepare people what it's going to look like when they're dying, so that they don't panic, right?
And of course, you only see that one side of it. I see the other side too.
Yeah, what does the other side look like? Because that's the only side I see, right?
Right. I mean, and I don't get lists of people who die at home or whatever, but when my patients are enrolled in hospice, I often will find out like how long they were in hospice, when they died, and our teams, because they have close tie, our palliative care team has close relationships with the hospice teams. They'll get reports of how long people survived on hospice when they died,
Hmm.
who revoked. So what you're talking about is revoking hospice, calling 911, coming back to the hospital. What's supposed to happen is that when things change, they call the hospice number directly, and the hospice will give guidance and will come out and provide an on call nurse to come and walk the family through that time.
Uh,
And really, most of the time, it's not that traumatic. Really, I promise. I don't know what the numbers are, but of course, in the ICU, you're seeing the ones that got reintubated and
yeah.
revoked. And,
Hmm.
why did that happen? There's so many potential reasons. A, they just panicked. B, they really weren't ready for that to begin with and just accepted hospice for whatever other reasons or whatever other benefits that they could get in the short term. And that really always was their goal at the time of a crisis.
Yeah.
Some people, they're just like, I can't handle the idea of my loved one dying in my house. I got to get them out of my house. So
Oh, oh, wow.
whatever
Okay.
the reasons are, we
I
just
see.
have to support them through that
Yeah.
time.
So so what are your tips and tips or pointers or pieces of advice for intensivists like me who how can we be better? How can we provide primary palliative care? I love how you said that. How can we better provide primary palliative care before having to call you in, assuming we have someone like Dr. Chen in our hospital? How can I better provide primary palliative care to my patients in the ICU?
Yeah. I think the most important thing is to put away our biases, put away our preconceived notions, and approach the patient and the family in as non-judgmental of an attitude as possible. And say, hey, tell me what brought you here. What are the barriers? What are you afraid of? And just ask and let them talk. And sometimes just letting somebody kind of share with you will give you a lot of insight into why something happened. So instead of coming across and saying, why did you end up back here in the ICU intubated? Like you come across like that and they're like, well, you're coming aggressive, so I'm going to come aggressive towards you too. But just kind of coming with a an attitude of humility and knowing that we don't understand what the situation and what the challenges are, and
Mhm.
trying to delve into what those are and problem solve those.
That's great advice. That's great. I mean, it's hard to do. It's easier said than done, and it's important to, I guess, to always remember that it's like you just don't know what people are going through, right? And it's important for us
Exactly.
to, yeah. It's hard. It's the ICU. It's very fast paced. It's hard, and it's we I think we have a longer attention span than some other clinicians. And at the same time, when you are dealing with multiply ill people who are multiply ill at the same time, it's difficult to take the time to get into the nitty gritty of what is going on to try to help. And it's important. And I really wish every ICU had a palliative care partner that can help with those. It's more than just like dumping the goals of care conversations, but it's also you have the time and you have the expertise and you have the knowledge and everything that can help us. So I think it's great that you are there. It's great that I'm lucky that I have you as a resource in the Rush System for Health, Dr. Chen. And thank you for all you do for us. And it's been wonderful having you. And thank you for your time today on Healthcare Musings.
Thank you so much for having me, Dr. Hasabala.
Thank you for watching. Sign up at healthcaremusings.com to get every episode delivered directly to your email. And please don't forget to leave a 5-star review. Thank you so much.